Good morning. Welcome to House Labor, Health and Social Services Committee. Good morning, members of the committee. Happy Monday. Hope everybody got some rest over the weekend. Members of the public and those joining us online and our LSO staff and intern, welcome. We will go ahead and call this meeting to order. Mr. Caldwell, if you call the roll.
Representative Clouston.
Here.
Representative Guggenmoss. Representative Heft. Representative McCann. Representative Ottman.
Here.
Representative Thayer.
Here.
Representative Wasserberger. Representative Yen.
Here.
Chairman Rodriguez-Williams. Madam Chairman, we have a quorum.
Thank you, Mr. Caldwell. All right. Just a friendly reminder, the committee does have rules of decorum. If you'd like to review those, they're on the handout out front of the committee meeting room. Remember to silence your phones and address the chairman at all time. You will be asked to state your name when you come up to testify. We have two bills that we're going to consider this morning. One is SF4 Medicaid rate increase EMS services and SF6 eligibility for Medicaid criteria. Both of these bills have come over from the Senate. At this time, we will put SF4 on the table for the committee's consideration. We do not have anybody here to present the bill, so I'll just briefly go over it, committee. This bill increases ground ambulance reimbursement to 100% of the Medicare rate. And there is an appropriation from the general fund, which I believe is 1.3 million. And then an additional 1.3 million from federal funds for consideration for this purpose as well. We will go ahead and open it up for the committee for any questions on the structure of the bill. If there are any. Okay. All right. Are there any government agencies that would like to come forward? Good morning. Welcome.
Good morning, Madam Chairman. My name is Franz Fuchs, Deputy Director of the Department of Health. I'm joined here by Jesse Springer, our state Medicaid agent. If I might, Madam Chairman, just have some background on kind of the EMS system as a whole and how this bill might fit into this, that system. So ground EMS, as you know, are ambulances that respond to 911 calls as well as transfer people between hospitals. Those are called inter-facility transports. In Wyoming, we have 44 EMS providers that service approximately 77,000 calls per year. The breakdown of that, roughly speaking, about half are 911 responses. 16% are inter-facility transports, so between hospital to hospital. Those are scheduled transports of patients. And then 34% are non-reimbursable, meaning that they may show up to a 911 call and maybe help somebody off the floor. And because they're not taking them to the hospital, they can't bill for that service. So they pretty much just eat the cost and kind of go back on duty. So that's kind of the rough breakdown of the 911 responses, the non-reimbursable and the inter-facility transports. As far as market share for the actual transports, so these are just the 60-some% that are reimbursable. Medicare covers the majority, so the 40 to 50% of ambulance trips are paid for by Medicare. Medicaid market share is somewhere between 10 to 15%, depending on the area. So it's a relatively smaller market share for those transports. And the remainder is going to be a mix of private pay, Indian Health Service, VA, other TRICARE, other smaller payers. Just as a rate comparison, if you just look, the billing is relatively complex, but if you just take an average inclusive of mileage, so that we essentially pay for the transport and then we add a mileage fee on top of that. So there's multiple codes that can be billed. For a 911 response, that's at the basic life support level, BLS, which is one of the most common levels of service. Private pay will reimburse or pay these ambulance providers $950.80. Medicare will pay on average of $576.24. And Medicaid will pay an average of $280.67. So that's the rough split of how those payers essentially pay on a unit basis. So this bill essentially, Medicaid in many respects is essentially like an insurance company, a large insurance company for low-income and disabled folks. Most insurance companies, when they raise the rates for providers, will build that into a premium increase that they charge their members. We do not, as a matter of policy or course, raise any rates for inflation or any other reason without asking you all first. So we ask for the appropriation for every single rate increase that we do. And this bill in front of you is one of those rate increase bills. And the idea is to take that Medicaid rate and bring it up to the Medicare level. So again, the Medicaid average paid for a 911 response, $280.67. And we're bringing that up to approximately $576.24. Now, those are averages inclusive of mileage. It's obviously more complex with the fee schedule, but that's in effect what we're doing is increasing that rate we pay to those ambulance companies. Madam Chairman, that's sort of a rough overview of how this bill fits into the overall system, but just at this point, happy to take any questions you might have.
Thank you. Committee, any questions? Mr. Fuchs. Representative Costin.
Thank you, Madam Chair. Thank you, gentlemen, for being here this morning. If we get the rural transformation funds, I know we can't use them for the reimbursement rates, but what can we use those funds for concerning EMS services in Wyoming?
Mr. Fuchs.
Thank you, Madam Chairman, Representative Clouston. So let me back up a little bit and talk about the biggest problem that we see with EMS generally. Particularly in rural areas and extremely smaller, some small areas of the state where we do have ambulance services. What you pay for with an ambulance is a cost of readiness. The ambulance pretty much has to be ready to go 24/7, right, to respond to calls. Many of these are staffed by volunteers, right? So they may be working another job and they get paged and they have to go to the ambulance and respond to that. But essentially, the average cost for a BLS level ambulance per year, if you were to value the volunteer's time and everything else, is about $500,000 a year. So that's you have this very high fixed cost for one ambulance. The number of calls, however, they respond to can be very low. So for example, there's a service out in the eastern part of Laramie County, Alban Rescue. They responded to 18 calls in 1 year. So you have this very high fixed cost of readiness, right? But you only respond to 18 calls. It doesn't really matter what the rate is. There's no way you're going to cover that $500,000. I mean, I guess the rate could be absurdly high, but certainly at 280.67, you're not going to pay that bill. So what they do is they subsidize that with volunteer labor, right? These volunteers are paid relatively, sometimes paid, sometimes not, but that's how they make the system work, along with tax revenue, maybe from a fire department, or maybe it's a critical access hospital that gets additional Medicare revenue to cover those costs. So at the end of the day, the biggest problem that we see, particularly in these smaller areas, is this mismatch between the high fixed cost and the very low volume that they have to cover that cost. So the idea for rural health transformation is to create incentives for these smaller ambulance services to work together and sort of regionalize. And the idea there is they can maybe consolidate and reduce their administrative overhead. So they maybe have maybe one medical officer, less billing overhead. You still probably need the same number of ambulances. You're not going to save any money on that, but you can essentially consolidate the administrative structure and save some money there, as well as being more interoperable and being able to kind of be more efficient in how you arrange your ambulances so they can respond to calls in the most effective way. That's kind of the goal for that. And to do that, the rural health transformation contemplates creating incentives that sort of match that fixed cost. So the idea is if you consolidate, if you on a voluntary basis, kind of agree to these terms that we're trying to lay out and work with, regional partners, we will pay you X dollars per ambulance per year to subsidize that fixed cost. So it's not based on volume. It's not based on anything revenue. It's really trying to match that fixed cost with a fixed revenue aspect to help support that ambulance service, but then also encourage that regionalization. That's really the goal of how rural health transformation fits in. So it does not replace, and it cannot replace, the Medicaid funds or any other revenue source. It really just tries to address that fixed cost, fixed revenue problem.
Representative McCann.
Thank you, Madam Chair. Could you explain, is the $500,000, is that for, explain that a little better as far as, is that a per ambulance, per region? Because that seems kind of pricey for one place. I mean, I've discussed this with one of the fire chiefs and he said it's $50,000 to run an ambulance per year. So I'm just wondering the discrepancy there. Could you explain that, please?
Mr. Fuchs.
Madam Chair, Representative McCann, so my guess, and I don't know, where that 50,000 came from, but the fuel, the maintenance, the ambulance, physical cost for the ambulance itself is much lower compared to the staffing costs. So when you have to have an ambulance ready to go with, a driver and someone else in the ambulance, times the wage for an EMT or paramedic 24/7, 365, that's where that $500,000 figure comes from. It's really the vast majority of that is labor cost. And so in the case of very small communities, they subsidize that through volunteers. So we're not actually paying, volunteer $18 an hour to sit around and wait for a call. They tend to be on call with a pager, and maybe they get a little bit every time they go out on a call. Maybe they don't get paid at all. They just volunteer. That's how it gets subsidized, and that's how they make it work. But if you were to value the cost of their time and the readiness, that's kind of where we get. And when you look at paid services, so in Cheyenne or other places where they have full-time ambulance services, that's again kind of where that $500,000 would be a very real expense for that ambulance service. And it's really mostly labor.
Representative Thayer.
Thank you, Madam Chair. Good morning, gentlemen. Fabulous rural health package that we have continued to talk about. I guess I just want to get some clarity that we keep talking that the rural health is going to pay for this on this program and this program and this program. And, we get so many programs, then there's only one pot of money. On money toward EMS service on the rural health, is it going to be a grant? Because some of the programs are set that they're going to get X amount of dollars. And a lot of the programs, these agencies or these entities are going to have to apply for grants. So it's not secure. So for me, making a decision on a bill like this, is it going to be confirmed money or will they have to apply? And so I just a little more clarity on the payment on that. Thank you.
Mr. Fuchs.
Madam Chairman, Representative Thayer. So the way this program is intended, and again, there's a lot that can happen between now and then, is the rural health transformation. We intend to use what we're calling the perpetuity to invest a lot of the funding that we receive. And from that, we will have revenue, very similar to how the permanent mineral trust fund generates, 30% or so of the state's general fund. And that is intended to be a very long-term revenue stream. So 20, 30, 40, 50 years, depending on how the return ends up being. The EMS component of rural health transformation is in that perpetual stream. So the idea is we would have $200,000 or whatever X is per ambulance service for a long period of time. But it is something they do have to apply for, and it's totally voluntary. No service will be forced to take the money or do what we ask in exchange for that money. But the idea is that it should be a long-term incentive. But we do not think it replaces the Medicaid sort of volume, right? And it certainly can't legally supplant that.
Follow up, Representative Thayer.
Thank you. Just that clarity, because I think there's kind of a misnomer out there that this is an end all to end all, and just making sure we know the details. Thank you.
Further questions? Vice Chair Altman.
Thank you, Madam Chairman. Mr. Fuchs, it's good to see you. With this, so if there's 2.6 million in the following years, and then this bill would go in, what is the criteria? Like, say there's in my county, say Lander applies and says, okay, we want to run ambulances and this, that, and the other thing, and then Pavilion does. What is the criteria to differentiate between who gets what and how much? Because there's 23 counties that we're looking at, and 2.6 is a lot of money, but with 23 counties, I just wondered how it was taken care of.
Mr. Fuchs.
Madam Chairman, Representative Ottman, so in the bill specifically is not relating to rural health transformation at all. This is purely Medicaid funding. And on the Medicaid funding, it's done on a fee-for-service basis. So for every transport, for every time they respond to a call and take a Medicaid patient to the hospital, they will get paid a certain amount of money. And this bill raises that price or that we're paying that ambulance service for that trip. And so it's essentially allocated based on the number of trips throughout the state.
Follow up, please.
Yeah.
Follow up, Vice Chairman.
I got going on the conversation rather than remembering. So if there is a populace that really has a lot of those charges and not a lot of repayment, then it would cover that.
Mr. Fuchs.
Madam Chairman, Representative Ottman, the person going to the hospital has to be on Medicaid already. It's not sort of just uncompensated care for someone that doesn't have any insurance. They would have to be on the Medicaid program. And Madam Chairman, I know Jesse might have something to add to that, if I'm just given a chance.
Thank you.
Madam Chairman, Representative Ottman, we're paying 66% of Medicare per trip. So part of this bill would be to look at the full 100% of Medicare rate, which is essentially like an urban rate. And that was discussed pretty extensively in the Senate. But in the last 2 years, Medicare has also added a rural rate, which is a small add-on of 2.5%. And then they also have a super rural tier, which, given that there's extremely low volumes in the super rural tier, and so super rural, and we use Frontier usually in Wyoming, is the smallest 25% of counties, rural counties nationwide. They're getting 26% more than Medicare. So there is this tiering now occurring with Medicare, which I think we could emulate. And that, again, is paid per trip for Medicaid. So we don't have any base payments. We don't have anything like that. But per trip, we pay a certain price, and we pay per trip, and then we also pay mileage. So every mile that runs, which is different than Medicare, we pay for the mileage separate from the trip, which really rewards the longer trips. But that's kind of the essential piece here is just that differentiation and adopting a new rate model. So we just haven't touched these rates in a very long time. And part of the discussion is just funding availability. You could make Medicaid pay whatever percentage of Medicare you want. It's all about how much funding we put in different pots. It's just a math equation. Do we have enough state general fund to get the 50% match to pay whatever rate the legislature decides?
Additional questions of the department? How long has it been since the rate change?
Madam Chairman, we have not touched these rates in over 10 years. There have been rate cuts since there's been iterative rate cuts. The only comment is there's been a supplemental payment program added, which allows the providers to contribute funding and get some funding. But absent that, there has been no rate increases. I've worked for the state for 14 years. I'm not aware of any within that 14-year period. So it's been a long time since these have been touched.
And just a follow-up question, is that due to lack of passing legislation? Have there been bills proposed in those 10 years, to your knowledge?
Madam Chairman, actually, the attention on EMS is really relatively new to see how severe this problem has. I mean, we've gone from fire to fire, and the new fire is EMS, to be honest. So I think EMS and maternity have been the new crises in trying to figure out how to help solve those issues, both with rural health transformation and with other funding. Those have been kind of the more pressing issues. I think there's just, to be honest, we've had budget cuts, and multiple years there was direction to have no requests. So for 4 to 6 of those years, we were either cutting or we were directed not to request anything. And just due to the state of the budget at that time.
Thank you. Representative Clouston.
Thank you, Madam Chair. Gentlemen, I'll just and maybe I confused the issue a little bit. So here's how I describe the two programs to my constituents. Rural healthcare transformation funds we can use to help pay for the equipment for EMS or maternity, right? This bill is increasing payments for what we pay the people that are helping save the lives or responding to the incidents. It's, I had said on the maternity thing, we are going to increase the payments for the people that are delivering the babies, right? And that's what Medicaid does. That's what those payments are for. That healthcare transformation funds we can use for the equipment or facilities. So to Representative Ottman's question, these are payments for doing the service, which are separate than the transformation funds, which are to buy equipment to provide the service, right? These are the provider's fees. So would you add anything to that? Is that a good explanation?
Mr. Fuchs.
Chairman Rodriguez-Williams, Representative Clouston, I think functionally that's how a lot of it is laid out. We are sort of intending a lot of these, in some cases grants, but some cases capital construction. But the EMS, in particular the EMS, there is that long-term sort of regionalization incentive, which can be used for anything. It's really just sort of matching that fixed cost structure. But yes, I think functionally it's equivalent.
Any further questions of the department? Okay, seeing none, gentlemen, thank you for joining us. Any other government agencies? Okay, seeing none, we'll go ahead and open it up for public comment. If you plan on testifying on this bill, please come forward. Good morning. You state your name and we'll hear your take on the bill.
Morning, Madam Chairman, committee members, Eric Boley with the Wyoming Hospital Association. First of all, I want to thank you for your hard work this weekend. I can't imagine how you guys are still going. Some of us watched it at home and we're already tired. So thank you for your work. I don't represent the EMS Association, but the Hospital Association works closely with them, and I don't see them here to testify. But during the interim, we did support this bill. I think you've asked a lot of really important questions. And I think we do really need to separate rural health transformation from this request. Our EMS services, and this has been a big priority for the governor's healthcare task force. We have brought legislation last several years. It hasn't made it very far. But I think this is a great start in fixing a growing problem. In our small communities, we're seeing our EMS services either go out of business or really decline in the services they're providing. We have seen some great examples of regionalization and services working together. But even with that happening, we're still running at a deficit in most places. And what I would say is, as you look around our state, there are a few for-profit services, and they're in those areas because they can make money at it. They wouldn't be there if they couldn't. And the areas that you don't see the for-profit private services are areas that are underserved and really struggle. And those are most of the areas that you live in. Up in Bighorn Basin, we've seen some great things happen where they're starting to work with Cody Regional, and several of the hospitals have come underneath that. The cities are helping out with some subsidization. The hospitals are helping out. We've seen in Star Valley where 3 individual services finally combined under the hospital, but they're still subsidizing that service tremendously. And then up in the Northeast in Gillette and Sheridan, they've really worked hard to create a regional approach. And I think they've already expanded all the way into Newcastle. I think they might be serving Lusk. And before long, they'll be serving other areas, again, at a loss. And so as we look at this, and I think it's important to look at the numbers. So Medicaid pays right now, based on the numbers that Department of Health gave, they pay half of what Medicare pays. And Medicare is not the gold standard, in my opinion, because Medicare pays about 87 cents on the dollar. So even if we raise it to the Medicare rates, which would be phenomenal because we're going to double what our EMS services are receiving for every Medicaid call, they're still running at a deficit. Realistically, you as a legislature could decide to pay anything you want. you could pay the commercial rate, which what you heard was $950. It would require half of that money to come out of the general fund, and the other half would come out of federal funds. But we could match commercial rates if we wanted, but we're not asking that. I think the rural health transformation funding, and I'm just going to touch on this, has great potential to help us build those regional approaches. But even if we do that, it doesn't address the payment issue. And that's what this bill does. And I think it comes down to one really simple question. Do you want EMS services in your communities or don't you? And that comes down to being able to pay staff. We've seen an increase in requirements for training for our EMTs. Now it's paramedics are required as well as EMT basics and EMT intermediates. Volunteers don't have the time anymore to vote, especially become a paramedic. And so we're seeing a decrease in volunteerism around the state. And so what we're seeing is a shrinking pool of providers and the ability to provide services in those communities with an increase in cost. And so in some of these communities, what we're seeing is, and this is where I think Deputy Director Fuchs did a great job, so we're seeing very high fixed costs when you consider that you've got to have a staff on call and ready to go 24/7 in these communities. So we think this is a Band-Aid, a good Band-Aid though. We think this is a good Band-Aid on a growing problem, and we would hope that you would advance this bill. It's $1.3 million, which seems like a lot, but in the grand scheme of things, when we look at the budget that we have, it's not much to make sure that we have what I could consider essential services in these communities. And with that, I'd be willing to answer any questions.
Committee, any questions of Mr. Bowling? Vice Chair Ottman.
Thank you, Madam Chairman. Mr. Bowley, how are you?
Good, are you?
Good, thank you. When we look at 1.3 out of the general fund, and then we're saying we'll get 1.3 from the Fed, and we could make that number whatever we want, how do we apply to the federal government and say, well, this is what we decided, so write us a check?
Madam Chairman, Representative Ottman, that's really what we do currently. And so there are state plan amendments, there are other documents that we file with Medicare with the state, with CMS, and the state has that ability to do that. So we already have that federal match in place. And so what is decided by this body that comes out of general fund is automatically matched at a 50-50 level. And I would tell you, our state's one of the lowest matches in the country. Some states have to put in 30% to get a 70% match, but we're one of the lowest in the country. So right now we're at a 50-50 level.
Additional questions of Mr. Bowley? Okay, see none, thank you.
Thank you.
Madam Chair, Committee, Tom Laycock with AARP Wyoming. We're a membership organization for those age 50 and over in the state. I did work with Mr. Bowley on the Governor's Healthcare Task Force. There's actually a subcommittee that works specifically on the EMS question, the EMS issue. And make no mistake, this is a big elephant that we're trying to take a bite of, one bite at a time. We're trying to solve the issue. The situation here is a little bit fascinating in terms of how EMS actually works around the state. As you've heard, funding an ambulance service in Wyoming is a patchwork system that depends on, really where you live. And so currently most residents in Wyoming don't pay any specific state. A lot of them don't pay any local taxes towards local ambulance service either. And so as a result, we've seen about 16 of these EMS services that have either folded into another service or just, kind of dried up altogether over the last 10 years. One of the things that we were asked to do in the Governor's Healthcare Task Force is ask that question of how important of an issue is this to our citizens. And so we were able to do a survey of 1,003 Wyomingites, age 18 and over. This was done in August 2024. At that point, the suggestion was 8 in 10 believe EMS should be an essential service. 73% believe communities should pay for EMS in the same way they pay for police and fire departments. Wyoming adults are generally willing to pay more for their community EMS systems, with 83% saying they'd be willing to pay at least something more per year. Now, that said, EMS is a bit of a victim of their own success, because 2/3 of the people that we asked for, they said, are you worried about EMS going away? They said no. And that's because we know when we pick up the phone and we call 911, someone always shows up. And so it's one of those things that people maybe didn't realize was in the peril that it was, our EMS system in general. So for us, it's a matter of, ambulance service being core to our ability to live independent in a state that has vast distances in wide open spaces that could be far from healthcare providers. So to that front, we'd ask for your support on this bill as we put in a little bit of money to help those that are first to answer a call in an emergency. As you heard earlier, 16% of those who are billed through EMS services are actually on Medicaid, so it's not like a huge populace that would be able to take advantage, that would be a part of this particular payment rate increase. But it's a group that, $2.6 million would absolutely make a dent. Happy to talk to you about that. Happy to talk to you about our take on rural healthcare transformation and what that does for ambulance service. Once again, quite a few bites going off on this big elephant, and we think all of them are pretty positive right now.
Thank you. Committee, any questions? Mr. Laycock? Okay, see none. Thank you, sir, for joining us.
Thank you.
Ma'am, please state your name. We'll hear your take on the bill.
Good morning, Madam Chair and Committee. My name is Micah Richardson. I'm with the Wyoming Women's Foundation at the Wyoming Community Foundation. And I won't repeat any of what has already been said, but just want to build on our support for this bill. As you know, EMS is a really important issue. And we are looking at this in terms of OB care. So according to some research done by state agencies, in 2024, there were a total of 703 requests for EMS services related to OBGYN and neonatal care, and 303 of those were for labor and delivery services. And so keeping in mind that this is also a piece of the puzzle when talking about maternal health care. And to the point, 33% of moms who give birth in this state are on Medicaid. Not to say that all of those use EMS care, but that they would be impacted as well. Thank you.
Thank you. Committee, any questions? Okay, seeing none, thank you for joining us. Any other further public comment? Please come forward and then, okay, come on up. Yeah. There's 3 chairs. Representative, good morning. Let's hear your take on the bill. Madam Conley.
Forgot who I was for a minute there. Thank you, Madam Chairman. Thanks to the committee. I'm here today because this bill is really important to me. Having worked with EMS for over 40 years, realizing what the billing situation's like and how things have progressed through those times. Years ago, EMS was probably nothing more than a hearse. Go pick somebody up and drive really fast to get them to the hospital. Now, we have people, and society has demanded this. We have folks that are paramedic level trained, intermediates, basic EMTs. Biggest share are, my experience where I'm at anyway, are basic EMTs and maybe an intermediate level. They have other jobs. And the training that goes with that is tremendous for them to be able to get the education they need now from what I told you earlier. So this bill really doesn't have a whole lot to do with the rural transformation program. But what it does do is it will help these smaller frontier rural ambulance services to cover some of their costs. One thing that people don't think about is you go on an ambulance call and sometimes people, a lot, will refuse your transport, or you're going to go get a call, 911, so-and-so is on the floor. Well, there's no charge for that. So the ambulance still has to expend their resources pay their people, wear and tear on the ambulance, wear and tear on the equipment, and they don't get paid for that. That's where this Medicaid rate increase would really be a benefit to the EMS services. An average call in my area anyway, if you added everything up, is at least $1,000, maybe closer to $2,000 now. And the reimbursement for this type of program covers maybe a third of that. So you're having to figure out where that other money is going to come from to cover the costs. And when you look at not only these costs that Medicaid and Medicare, this bill would cover, they also have, which I guess is where this rural transformation thing is. But right now you've got radio communications costs. You have to have comms in your ambulance. You got to be able to talk back to dispatch. You have to have things like defibrillators. And now we have new technology with those where you can have telemetry. So you can hook your patient up. You can send your telemetry information back to your hospital. And they can determine then, do we take these people? Where's the closest facility to take them? I mean, it's tremendous how far we've advanced, but we haven't advanced with our volunteers and paying them. Because to take the training that you need is, they've pretty much doubled and tripled hours that you need to have your training to be able to do this. So we've about come to the place where true volunteerism is really not there anymore. And so, I mean, I could go on, but I'll stop. This is just a really good way to help supplement the ambulance services. Thank you.
Thank you, Representative Connolly. Committee, any questions? Okay, seeing none, thank you, ma'am. Good morning. If you'd state your name and we'll hear your take on the bill.
Good morning, Madam Chair. My name is Mike Jones, Fremont County Commissioner and committee. Thank you for the opportunity to talk a little bit about EMS. We have struggled in Fremont County for years, as our representatives will attest, struggled to maintain that service across a vast distance in Fremont County. We are definitely a frontier medicine environment. I would say this is an important piece of the pie. There's community engagement going on right now, trying to raise funds through a sales tax. There's been efforts to lower costs. We continue to struggle in this area, and this is an important little piece that would add to helping defer some of those costs that we've incurred. Give you an example, we ran our own ambulance service with volunteers in 2015. It was a $3.6 million budget, and we subsidized it by $650,000 at the end of that year to cover for the loss of payment that's reimbursement. About 25 to 30% of our calls are no transports, which means they don't get paid for it. So I could go on and on with the sad story, but we appreciate any help you can give us to kind of defer those costs over time. Thank you.
Thank you. Committee, any questions? Seeing none. Okay, sir.
Good morning, Madam Chair, committee members. I'm Robert Short, Commerce County Commissioner. And much like my colleague represented, obviously frontier medicine is the call of the day for most Wyoming counties. In my county, we have an ambulatory service that's run by the hospital. That service we subsidize as county commissioners every year to try to help defray some of the unreimbursed expenses. I did some simple math listening to the statistics that were given to you earlier. Based on a 16% call rate of 77,000 ambulatory calls per year, that's approximately 12,000 calls that are associated with Medicaid. On $235 reimbursement rate, that puts you somewhere around $3.1 million in reimbursements on a $7.2 million expense. So as you can see immediately, just based on that, we're at a $4 million deficit. If we start to look at what the rates are that it costs to actually run an ambulatory service, if we use $18 as a metric, and I'm not advocating for $18 for pay for anyone because that's basically poverty level in our state, but $18 per year over 365 days for 2 people is greater than $310,000 in costs just to staff that service. So if we start adding all of these numbers together, we can see that there is a massive deficit that ambulatory services face in order to actually provide the services that we're hopeful that we will give to the citizens of our counties and our state. So I would urge the committee to please forward this bill to help offset some of those costs so that people in our state can get those ambulatory services when they need them. Thank you, Madam Chair, and I'll stand for any questions.
Thank you, sir, for your testimony. Committee, any questions? Mr. Short, Representative Hoft.
Thank you, Madam Chairman. Mr. Short, I'm curious if we could make this up with a people's referendum per county. Let the folks at home make a choice. Could you tell me what the difference you think that we would be able to do something like that?
Mr. Short.
Madam Chair, Representative Heft, I'm not quite sure I understand the question.
Representative Short.
Madam Chairwoman.
Representative Heft.
Madam Chairwoman, Mr. Short, either a mill levy, something like that. Would you think that there would be, I mean, my county's in pretty good shape, but what about some of the others?
Mr. Short.
Madam Chair, Representative Heft, I suspect there's a chance with the EMS law that was passed, I think last year, if EMS districts were established, then perhaps there's a way to offset some of those costs. But again, I think, for example, I can only speak to Commerce County where I have a little bit of knowledge. We subsidize the ambulatory service over $1 million a year out of the general fund in Commerce County, and the hospital still posts a loss against those ambulatory costs. So I'm not sure where that would have to be set, if you will. Obviously, it would be based on valuation in the county, et cetera. So I would guess that it would help offset some of it, but I cannot say specifically that it would, cover the costs. And I just have to run some math.
Additional questions of the commissioner? Okay, seeing none. Thank you, gentlemen, for joining
Madam Chair,
us.
may I add?
Sure.
So the EMS bill provides the ability to add that property tax for an EMS district, which you can add from 2 to 4 mills on that. Again, that's one piece of the pie. The downside of that is that it is a property tax, and here we are in a major discussion around property tax relief. I mentioned the efforts that we're taking, and this is a community-wide effort to look at a sales tax. Unfortunately, that would have to be renewed regularly and that sort of thing, and sales tax can be volatile, but we are working on that, and I think it is important that every community weigh in and measure their commitment for having ambulance service, as well as a state contribution and federal as well. And that's why I feel like this is a nice little important piece here that we can add to that conversation. Our subsidy every year for ambulance is $2 million. Thank you.
Thank you, gentlemen. Thanks for joining us. If we can bring the department back up, I have a couple questions. Thank you. Okay, so on the topic of rates and comparison across the state, when we look at wages, EMS wages, obviously there's probably a difference between compensation in Wheatland and compensation in Jackson. If the committee were to decide to approve this amount, and there's $2.6 million added for reimbursement, looking at the balance across our state, I mean, is it fair to say that perhaps one area of the state might eat up more of the costs based on demand and based on wage comparisons.
Madam Chairman, just a couple things. One is the Medicaid rate is the same regardless of the, obviously there's minimum standards for the, qualifications for EMTs, but Medicaid doesn't really pay, it pays in a very gross way, like there's advanced life support versus basic life support. Those are the two differentiated services, and then maybe a couple others out there. And those have some minimum qualifications for ALS. I think it is paramedic. For the BLS, it's EMT. But we don't necessarily pay based on wages of the personnel that are transporting. It's just based on those two services, and there's no geographic multiplier based on, if you're in Teton County, we don't pay more than in Niobrara County. I will say that most of this money will, because Medicaid is fee for service, it's volume based. This money will follow the volume. So where there's more people and more Medicaid members, that's where most of these funding will go.
Thank you. That was going to be my next question, was on volume. Okay, so that's fair to say. And then I guess my second question, I do realize, this is strictly reimbursement and an increase in the reimbursement rates, but we have brought up the role transformation. And I'm just curious if the department weighed in on any or sought any input statewide on the potential impact that role transformation could have when it comes to equipment statewide, like when it comes to interest across our state for that funding. I would assume that there was probably some information sought across the state before we decided to apply for the federal money. And I guess my follow-up would be, if we are freeing up money for some of these districts and some of these areas that are providing regional services when it comes to equipment using regional transformation funding, potentially, if they were to receive it, that to me would also be a benefit. It would allow other freed up money, so to say, when it comes to personnel and reimbursement.
Madam Chairman, just to kind of get to your first question, we did have a bunch of, by bunch, I mean 8 in-person town hall meetings around the state in rural areas. We had 3 online meetings, but the goal of those meetings weren't really to get at solutions. They were more trying to ascertain priorities and problems. So we asked folks, what do you think are the biggest challenges your community faces? And from that, we developed a list of around 36 distinct priorities that we heard around the state. And we did a statewide survey that was online, and we got about 1,300 responses to that survey. And that asked people to kind of pick, if you're given option A versus option B, what's more important to you? And it forces them to choose one of those priorities. And then they go to the next randomly selected pair. So out of that exercise, really what we got, the bottom line that we understood from the feedback was that people really wanted to prioritize the basics. It really was about primary care, maybe integrated with behavioral health. Ambulance EMS was up there. Hospital sustainability was up there. People were not asking for frivolities by any means. It really was about the basics. So to your question about the public engagement, that's kind of how we did it and the conclusions that we derived from that exercise. I will say that, the rural health transformation, the way we've structured this, the EMS portion of this is really to try to address that underlying problem of those really high fixed costs and the really low volume in certain rural areas. So in many ways, I'd say it's more complementary to this bill. It's not supplanting or replacing the Medicaid funding, because the Medicaid funding does kind of look at the volume side of things. Rural health transformation is more about sort of that fixed cost and capacity. Madam Chairman, hopefully that answered your question.
Okay, thank you. So just piggybacking on the original question and the statement that the money will follow the volume. Obviously, Cheyenne's going to have a lot more calls than another smaller community in our state. Is there any way, if this money were allocated, that the department could balance to make it more fair, more even, so that our friends in Fremont County or Converse County see a piece of that pie, so to say? Is there any mechanism in place already, or any thoughts about it?
Madam Chairman, I'll defer to Jesse on that because I know we're looking at different rate models for Medicaid.
Madam Chairman, this is Jesse Springer. For a long time, Medicare had a single rate. In the last few years, they've developed a rural rate and a super rural rate. And it does create the mechanism for us to have separate fee schedules for different areas that are still based on Medicare. So we've done this actually in durable medical equipment, and it's worked great. So we were having a hard time getting oxygen delivered to really rural areas. And they were reporting, hey, we take a loss every time we take that out, 50 miles. That just doesn't make sense for us. We're not going to deliver oxygen. We're not going to deliver certain equipment outside of these certain areas. And so we, a few years back, the legislature approved as part of the budget, a rural fee schedule for durable medical equipment, which is based on Medicare. So it's 100% of Medicare. But it's using the regular fee schedule and the rural fee schedule, and and it's based on the person. So, and that's how Medicare is doing it on ambulance as well. So they're saying where the person is picked up, not where the service is based. That then triggers which fee schedule it goes into, and if it's in a rural area. Then, and this is how we're doing it on durable medical equipment. If the person is in a rural area, then it triggers a higher rate to compensate for those extra costs and a higher cost structure. So the thought here, because there is such low volume in the rural and the super rural areas, that likely we can, with this funding, still adopt that type of model, which would move to a separate fee schedule for rural, which would just be a small add-on, which is 2%, and then super rural would be much higher. So current year is 26% higher than normal Medicare. But those super rural areas have very small number of trips. So they're, from a budget perspective, it's not a budget breaker because yes, we are going to pay 26% more, but it's on 5% of trips or something like that. So it's the math is still sustainable within the amount of money that we're talking about here. Hopefully that's helpful, but that is the structure. So the super rural is based on the smallest 25% of counties. We have not kind of done that calculation, which counties would fit that definition. I tried to find it to say who is Medicare defined as super rural, but we weren't able to find it in time yet. So we probably will just do that calculation ourselves. We could likely define our own definition of super rural if we'd like. We're not necessarily limited to the Medicare definition of what frontier or rural is. And likely we would do that per service. So we go per service and say, how many trips do they have? What's their, mainly because you get certain communities that the county might look very urban, but portions of that county are extremely rural or very distant from other care and are very expensive. So, one service may be super rural while the other is urban in a number of counties in Wyoming.
Thank you. Hey, any additional questions of department? Thank you. Oh, one more. Representative Thayer.
Thank you, Madam Chair. Just for clarity, and if this is a true statement, just for my knowledge on this bill, when the Rural Health Transformation Program was signed in July of 2025, or setting everything up, is it true that there were reductions to Medicaid reimbursements? And if that is true, then how does it affect the Medicaid pay for EMS?
Madam Chairman, Representative Thayer, it is true that nationally there were significant cuts to Medicaid, but Wyoming was not affected by those cuts.
Thank you. All right. Thank you. Any further public comment? Anybody online, Mr. Caldwell? No. Okay. Thank you. We'll go ahead and close public comment. Committee, what is your pleasure? Bill's been moved by Representative Clouston, seconded by Representative Thayer. Discussion amendments. Discussion on the bill? Representative Thayer?
Yeah, I am honored for this, Senate file 4. In a county, I'm representing counties, Carbon County and, House Districts 47 and 15, or I'll just talk 15 is, being the third largest geographic, county in the state, it's almost 8,000 miles. And I can tell you that we have volunteers that are coming from Rollins because of a lack of volunteers, as we had testimony earlier, going from Rollins over to Saratoga. And so they have to even just get to that ambulance bay. And so I am absolutely for this. I don't like to spend money. My husband thinks differently, but on and for this. But it's just really important for our county.
Further discussion? Okay, seeing none. Representative Gugemast?
Thank you, Madam Chair. I guess I'll just share my thoughts on this. To me, this bill, from the testimony we heard, it sounded like this is a big problem, and this 2.3 million will be a small bite out of this problem. So my question is okay, how much money are we talking to solve this problem? I look at this bill as not thinking outside of the box. It's just putting it on the state to try to solve it with money. And I like the idea of, with the diversity of our communities, size and distance, I would like to see it be more locally addressed rather than the state, because like I said before, the testimony was 2.3 million will not solve this problem. So my concern is, okay, then what are we really talking about down the road? Next year, the following year, how much more money is going to be requested, and will it ever end? So I think I'm going to be against this bill. So just my thoughts. Thank you.
Further discussion or amendments? Representative Yin?
Madam Chairman, thank you. So I always liked, because it's a committee bill, we all voted on it already in the interim. And I always like looking back to see how we all voted. We all voted in favor of it because I think it was very clear during the interim that it is a problem. I think when it comes to Medicaid reimbursement rates, I mean, that's what this bill is about. It's about, we already have Medicaid, it exists, and we underpay significantly for the services that we're asking these providers to provide. This is still underpaying them. I mean, it's underpaying them. I mean, if we said we put in market rate, I mean, that would make more sense, frankly, because we should be paying for these patients that we say need help being paid for the rate that it requires to provide the services, but we don't even do that, right? So it really does shift some of the burden onto insurers, or we just don't have the service. And so I think we know that there's a problem, and so we should do something about it. And the very least we can do is pay for the services that we're asking providers to provide for patients that we say qualify for Medicaid. Thank you, Madam Chairman.
Thank you. Committee, any further discussion? Representative Clauston?
Thank you, Madam Chair. So yeah, I'm in support of this, and I agree with both the representatives. This doesn't fix the problem, but it starts to help with the problem. You know, we haven't increased what we pay for these services in Medicaid in 14 years. We're at 68% of the cost. Again, it doesn't fix it, but at least it helps put it towards the problem. You know, if we do get the rural transformation funds, we can have all the nice equipment that we want. But if we don't have anybody to drive the ambulance and give the care, what good is it having these services, you know, have an ambulance sit there? I do think there's some other combinations we can do in the future, maybe with, I'm always amazed when I see an ambulance and 2 fire trucks show up at the same house, right? I think that maybe there can be some combination of services that could be better utilized, but you know, these services are expected. They're important to the people of Wyoming. And I think we need to make this small support. So that's why I'm in favor of it.
Thank you. All right, follow-up, Representative Guggenbos.
Thank you, Madam Chair. One thing in my area that is being looked at and considered is local funding, doing a, say, like 1% optional sales tax. In my estimation, that's a good way of going. That way everybody gets to decide, and if it is a real need, people will vote for it. And if it's not, if things are working well, it won't be voted for. So I like giving the people the choice. Thank you.
Okay, further discussion, amendments? Seeing none, sensing the urge to vote. Mr. Caldwell, if you call the roll on SF4.
This is a roll call vote for Senate File 4. Representative Clouston,
Aye.
Representative Guggenbos,
No.
Representative Heft, Representative McCann, Representative Ottman,
Aye.
Representative Thayer, Representative Wasserberger, Representative Yen.
Aye.
Chairman Rodriguez Williams. Madam Chairman, that is 5 aye, 3 no, and 1 excused.
Okay, SF4 has passed. Move on to the next bill, which is Senate File 6, eligibility for Medicaid criteria. Okay, this bill also was a committee bill. Essentially what it does is it codifies current Department of Health rules pertaining to Medicaid eligibility and including U.S. citizen, proof of U.S. citizen requirement, citizenship requirement, should I say, and Wyoming residency requirement as well. Any questions on the structure of the bill? We do have an engrossed version in your hands, the blue copy. Okay, seeing none. All right, are there any state departments that would like to come forward? Government agencies. Good morning. Would like to go first.
Sure, Madam Chairman. Jesse Springer with the State Medicaid Agent with the Wyoming Department of Health. I'm here with Franz Fuchs, Deputy Director of the Department of Health. We'll just stand for questions. I will note that the bill was heavily amended in the Senate, just mainly to add groups that we currently cover. So there's a more specifically noted. And the main change was just to note the bill as written as a committee bill specified all the current populations. What the Senate committee did was amend to specify those a little bit more detailed, including like tuberculosis, breast and cervical cancer treatment, especially when those populations are elections the state may have taken 20 or 30 years ago, but are considered to be optional, just to make sure that that's 100% clear that the state wants to retain its current coverage. To be clear, it's only listing people that would be covered, and that it's reflecting the current status. There was discussion about effective date being either January 1st or July 1st, and discussion in that committee about are there a lot of changes occurring? There's been no coverages changed. It's not a common event. So there's not going to be any changes in coverage between January 1st, 2026 or July 1st, 2026. So I think the committee decided to go with January 1st, 2026. But our testimony was that had no effect because there's no planned changes to to eligibility. And to be clear, the department has never changed eligibility without direct budget footnote direction from the legislature or a statute to say cover this population. So this is doing what is done in the rest of Title 42. For instance, on services, the services we cover are authorized by the legislature. There are no services that Medicaid covers that are not on that list of services. This is taking the same approach with populations we cover to specifically list who is covered. And if the legislature would like to add a population in the future, they can now go into this new section of statute and specifically add that population.
Mr. Fuchs, do you have anything? Okay. All right, committee, any questions of the department on the bill? Representative Clauston.
Thank you, Madam Chair. Thank you, gentlemen. I'm just trying to recall from our summer discussions, were there some populations that we discussed that are not covered in this that we should be looking at, and maybe something we could look at in the interim?
Mr. Fuchs.
Madam Chairman, Representative Clauston, there were a few minor, very small populations that were amended into the Senate draft that we currently cover, but there was nothing in here that would be speculative or that we don't cover now that would direct us to cover, if that makes sense.
Vice Chair Ottman.
Thank you, Madam Chairman. And I know sometimes you probably wonder why we ask these questions because you've already answered it, but nevertheless. Okay, on page 2, there's an applicant shall be a Wyoming resident or meet the criteria specified in the Wyoming Medicaid state plan. What is that criteria?
Mr. Fuchs or Mr. Springer?
Madam Chairman, Representative Ottman, the residency statutes are that we have to have someone prove residency, or for instance, like someone who's being transferred here with the military, they prove that they are going to be here and what date they're going to be here, like transfer documents. So we are confirming their residency as of a certain date, or that they will have confirmed residency as of the date their eligibility would start. So that's the definition under our current state plan. So someone has to be a resident. So if we confirm they're not a resident, then they cannot be eligible. They could be eligible in whatever state they're a resident of, but they wouldn't be a resident of Wyoming. And the Wyoming Medicaid program only covers residents of the state of Wyoming.
Follow up, Vice Chair Ottman.
Thank you, Madam Chairman. And on page 3, there's a lot of, I'm taking it as that these were additions or changes to the bill. And it says in section A, be determined disabled or be entitled to receive supplemental security income or be eligible. C, be entitled to receive hospice services. Could you just kind of give us an idea of why all of these individual determinants were added to this? I mean, if it's in the main gist of the criteria, why is it added again?
Mr. Springer.
Madam Chairman, Representative Ottman, these specific items are really laying out the different forms of disability, but in some cases, hospice is not considered to be a disability, for instance. So the bill said we'll cover disabled people, but this is laying out to say someone who actually needs hospice isn't truly disabled by a number of federal definitions. They need hospice. So it's trying to lay out, these are the populations we currently cover, and to be as apparent and clear as we can on this is exactly who we're covering right now. A number of these populations are mandatory. Some of them are not. But these disabled populations, Social Security, supplemental income, and the hospice are mandatory populations, but this is just being clearer that those populations are covered.
Follow up, Vice Chair Ottman.
Thank you, Madam Chairman. Okay, and thank you for that. But on the idea of the hospice services. It had long been thought by me that usually when someone went to hospice, that was a short-term answer. But these days I'm seeing at some of the facilities that it can be months and months and months. So if this says for not less than 30 consecutive days, does that not cover the short term and does cover long term?
Mr. Springer?
Madam Chairman, Representative Ottman, that or is important in that sentence. So the received hospice services, ideally there'd be a comma there, or, a clear break in the thought, or resided in a medical institution. So the 30 days is actually for nursing home. So 30-day stay in a nursing home or 30-day stay in a inpatient hospital also triggers Medicaid eligibility. So if you're if you're medically eligible and you're financially eligible, but hospice stay on its own, yes, actually most of the states that we pay for are quite short. So there are some rare instances that they go over long periods of time, and I do think that's been a bigger problem in other states where hospice has been somewhat misused. But our residential hospice and our home-based hospice, and there's also hospice that occurs in nursing homes. It's not been long-term in Wyoming. It's not been the same sort of problem that maybe California has experienced, where people are in a hospice for multiple years.
Thank you. Representative Thayer.
Thank you, Madam Chair. And just gonna segue on Representative Ottman's question is, if I'm reading this correctly, at the bottom of page 2, it actually says an applicant shall, and starting on line 21, an applicant shall fulfill not less than one of these, and then you go to the next page. So as I'm reading this, they have to be not less than one. So I don't know if that clarifies for you, Representative Ottman, that it's not all of these, it's just not less than one.
Additional questions of the department? Comments? Okay, seeing none, thank you. We'll open it up to public comments. Is there any public comment on this bill? Okay, no public comment. Anybody online? Okay. All right, with that, I'll close public comment on Senate File 6. Committee, what is your pleasure?
Move the bill.
Bill has been moved by Representative Clouston. Second by Representative Thayer. Discussion amendments. Okay, question being called. Mr. Caldwell, if you'd call the roll on Senate File 6.
This is a roll call vote for Senate File 6. Representative Clouston.
Aye.
Representative Guggenmoss.
Aye.
Representative Heft. Representative McCann. Representative Ottman.
No.
Representative Thayer. Representative Wasserberger. Representative Yen.
Aye.
Chairman Rodriguez Williams.
Aye.
Madam Chairman, that is 7 aye, 1 no, 1 excused.
Senate File 6 has passed our committee. We have no other bills on the agenda today. I will give you, committee, just a brief notice ahead of time here. We will discuss our interim topics on Wednesday, March 4th at noon. So put that on your calendar for a future date. And we will continue to hear Senate files that are referred to us in future dates. So with that, our meeting is adjourned. Thank you.